Hi, I'm Marvin Natowicz. I'm on staff at the Cleveland Clinic, and I'm a professor at the Case Western Reserve University School of Medicine. And we're very fortunate today to have Dr. Greg Holmes, who is Chair of Neurologic Sciences and Professor of Neurology and Pediatrics at the University of Vermont College of Medicine. Dr. Holmes is an esteemed clinician and researcher in the field of child neurology with a particular specialty in epilepsy. He's received numerous honors. He's received an award from the American Epilepsy Society Research Award, as well as several other extremely prestigious awards, such as being awarded the Sachs Lectureship of the Child Neurology Society. Thank you very much for being here today, Dr. Holmes.
Thank you.
We'll be talking today with Dr. Holmes about autism and epilepsy. And the format for today's discussion will be the presentation to Dr. Holmes of several interesting and important clinical cases that are all hypothetical but realistic. And we'll hear from Dr. Holmes how each of these cases might be approached and what are the important clinical pearls to distill from each of them. So to begin with, I'd like to present the case of a hypothetical, recently adopted 3-year-old boy with a diagnosis of autism who is referred to Dr. Holmes' clinic. The new parents of this adopted child have noted intermittent but frequent repetitive movements of the arms that they feel are, quote, strange, and without apparent relation to any obvious cause. They also noted prolonged episodes of visual fixation. And those episodes of visual fixation are sometimes associated with looking at very intently spinning or turning objects, such as a rotating fan or a spinning wheel. And these new parents are concerned and sought out Dr. Holmes about the possibility of their child having seizures. So this, in turn, raises several questions for an expert like Dr. Holmes. How does one differentiate stereotypies and other unusual movements from movements that are observable in some types of seizure disorders? And related to that is, how does one differentiate between prolonged visual fixation that can be part of some autism phenotypes with the staring that can be noted in some types of seizures?
Yes, this is a very good question, because I think it's something we see on a very frequent basis. Parents with children with autism that will develop unusual movements and also the staring episodes. And so I think it's really important when we first see the patient to get a good history of what they're actually observing. And I typically have the parents mimic the events the child is having in the clinic, if the child doesn't happen to have those events in the clinic. And then I also, even before the patients come to the clinic, I try to get the parents to take a video. Usually I've talked to the pediatrician about the case already, and so try to get a video of the movements they're describing. So autism is characterized by repetitive, stereotypic behavior that's often occurs frequently, of course, during the course of the day. It often involves motor activity, movements of the arms. But usually the character of the movements is a little bit different than what you see in seizures. The seizures, the type of motor activity we see is usually tonic activity, where the child becomes very stiff and rigid with their eyes open, or they may have myoclonic activity, where there's a very sudden jerk of the body. Sometimes the child will fall down to the ground during these episodes. Or they may have focal seizures with the automatisms, which can consist of some arm movements, but they're usually not like what you see in children with autism, the stereotypic behavior. The children with the autism typically have more irregular kind of movements. They are very stereotyped. They come and go. May occur more during periods when the child is anxious, and sometimes can be broken when the parents can divert the child to activity. But I think sometimes it can be difficult in the semiology of the stereotypic behavior in children with autism versus those with epilepsy. At times can be challenging, even when you're standing there with the videotape in hand. So in those children, we often will, if we're not sure, we'll often try to get an EEG on the child. Staring is probably even more common referral, especially the child that fixates on a ceiling fan or something moving. And they are usually different than what we see in children with epilepsy, which would be called petit mal epilepsy or absence seizures. In absence seizures, there's a real clear onset offset to the seizure. They last less than 15 seconds. In staring as its only component is actually unusual. Usually the children have some eye blinking, a change in facial expression. They do not respond to what's being said to them. And when they come out of the seizure, they get right back to where they were. And they may even be aware of they had a seizure due to time lost. Where the children that have the staring attacks with autism, they seem to be almost tuning out. They may not respond to stimulation of the parents. They often last longer than what you see in absence seizures, and tend not to have such a distinct onset and offset of the two. Most of the time, if you just get a child with the staring episodes and nothing else, and you do an EEG, and this has been done many times, the EEG is usually normal during those episodes of staring versus a child with absence seizures. Again, I think the clinical history, observing these, can often, by an experienced clinician or pediatrician, can usually distinguish the two pretty readily. But sometimes we do have to proceed to an EEG because not everything is black and white.
I see. Great, great. Moving on to a second clinical scenario. This one, Dr. Holmes, involves an ambulatory, nonverbal, 10-year-old female who has a clinical diagnosis of PTEN, gene-associated disorder, who has marked macrocephaly. She has a head circumference that's more than 5 standard deviations above the mean for age and gender, who has mucocutaneous papules, mild global hypotonia, and a non-focal neurologic exam, and she was referred to your clinic. When she was 3, there was a history of language regression with a loss of social interaction and loss of eye contact and development of stereotype movements. And developmental assessments at that time established diagnoses of autism and profound intellectual disability. Further workup showed an apparent de novo or newly occurring pathogenic DNA sequence variant of the PTEN gene. And now, at 10 years old, she presents with several focal seizures, and an EEG showed focal spike wave complexes over left temporal region. And so some questions for you, Dr. Holmes, are, many persons with autism have macrocephaly. What is known about the relationship of macrocephaly and autism? And is this person's macrocephaly in any way potentially different and a potential clue as to an underlying identifiable process? And if that might be, how might one proceed in this particular case to further evaluate the patient?
Yes, this is a very interesting case, and I think first seeing the child and it stresses the importance of doing accurate head circumference measurements. And I think if there's any doubt when you see the patient, you should do the head circumference yourself as a physician. But certainly 5 standard deviations above the norm would be quite concerning. Now we see increased head circumference in children with autism fairly frequently. It's a little more common maybe in boys and girls, although autism is more common in boys than girls. The the finding there has generally been that it's usually during the first few years of life where you see the increased head circumference, and there tends to be a leveling out. So at her age and with that history, and certainly knowing the PTEN mutation, I'd be very concerned about what's happening to her. So and already she has sounds like a fairly clear-cut history of seizures. So she needs to be thoroughly evaluated and most likely treated for her seizures. So the PTEN is similar to another disorder that's highly associated with infantile spasms, tuberous sclerosis, where you tend to get overgrowth of tissues, hamartomas. And this is a type of patient that I would want to have a team involved with her, because this is not a condition that just involves the brain. The children can get brain tumors. It's a little unusual, but they get tumors elsewhere in the body. So the thyroid, uterus, GI system, polyps can occur. So you need a ringleader. Usually the leader that can handle and direct her care, and that's usually through the pediatrician. But someone that you would have multiple specialists involved, including GI, endocrinologists. They can get skin lesions as well. And certainly someone that I would want to do imaging of her head, an MRI scan, get the EEG, and likely begin her on treatment. The treatment for focal seizures would be you'd want to use medications that would not exacerbate or contribute to her autism. So you tend to pick drugs for focal seizures such as carbamazepine, oxcarbazepine, drugs that are used for focal seizures, lamotrigine, that could be fairly behavioral neutral but effective in controlling focal seizures. I think you'd want to avoid drugs that could exacerbate some of the anxiety these children can get, or their irritability that can occur. And so you want to avoid drugs in the benzodiazepine families, such as clobazam or clonazepam. And likely in this particular patient, levetiracetam would not be one of my first choices of drugs, because it can lead to a lot of irritability. So this child has, unfortunately, is faced with a lifelong series of problems, has to be followed very carefully over the years. And so you don't want to make the situation worse. Epilepsy is just one part of her problem. And you want to be sure you're not just focusing on that, and you have to really focus on her quality of life with your choice of management, and then she needs plenty of supportive services from your colleagues in regards to her underlying condition.
Right. Thank you. And so it would seem from a diagnostic point of view, one of the tip-offs early on was that this isn't the typical macrocephaly that one might see in many persons with autism, but her being so many standard deviations greater could suggest the possibility of a syndromic process.
You're absolutely correct. That is the way off the scale as far as large head, yes.
Okay, and that would direct additional investigations. Another clinical scenario that I'd like to present to you involves a hypothetical 5-year-old male with autism who's referred to you for additional evaluation. He has had normal early development apart from some speech delays. But at 2, he lost the approximately 10 or 20 word vocabulary that he had acquired, and he lost some social skills. And this occurred without any apparent antecedent or concomitant. There was no head trauma, there was no illness at that time. At about 3.5 years, he now had little expressive or receptive language function and had multiple episodes of screaming, as well as self-injurious behaviors and also had episodes of generalized seizures. The general physical exam at 3.5 was unremarkable. The neurological exam in your clinic showed hyperactivity, inattentiveness, a lack of expressive language, a lack of social interaction or play skills. The actual motor exam was unremarkable. At about 4 years old, the child underwent a formal neuropsychological evaluation that was consistent with the diagnosis of autism, both by DSM criteria as well as an ADAS. And the family history turned out to be notable for 2 younger siblings, a boy and a girl, who both had global delays and seizure disorders, and a mother whose history may or may not be significant. She had severe migraines. And lab investigation of this child showed mildly increased blood lactate, increased plasma alanine on a blood amino acid analysis, and increased levels of several Krebs cycle intermediates and lactate on the urine organic acid analysis, all of which prompted evaluation of the mitochondrial genome that ended up showing heteroplasmy of a maternally inherited and pathologic mutation in a mitochondrial tRNA for lysine. So several questions for you that relate to this case are, in addition to this child's autism, the child clearly has metabolic abnormalities relating to dysfunction of mitochondrial bioenergetics, and this is on an inherited basis. Is the category, the general category of mitochondrial energy disorders, a category of conditions that's known to be associated with autism? And is it known to be associated with epilepsy?
Yes, the answer to both those questions is yes. So individuals that have a mitochondrial disease tend to have a higher incidence of autism, and patients with epilepsy also have a higher incidence of autism. The autism is, the mitochondrial disease does not have to be specific to one condition. It can involve many different syndromes that can be genetically confirmed.
Many different mitochondrial syndromes?
Yes. In addition, there's some children that have evidence of mitochondrial disease in which their genome is, the genetic defect has not been detected. In other words, they have the biochemical markers of dysfunction, but the gene has not been detected. So there is a good association between autism and mitochondrial dysfunction. And the same goes for epilepsy as well.
Now, if a child has a definite primary underlying genetic cause for the epilepsy and or for the autism, especially the epilepsy, let's say, does that potentially change the management?
Yes, I think you have to be very careful with certain metabolic disorders and that you do not make them worse. So especially with mitochondrial disease, how you would go about treating this child would differ from a child that does not have mitochondrial disease. So in this case, I think it's great that they determined that the child does have mitochondrial disease. For example, you would not want to use a seizure medication, the seizure medication valproate in this patient because it has been shown to be associated with mitochondrial toxicity. We sometimes do use it in the mitochondrial disease, but it's usually one of our last resorts. And there are a number of other medications you would like to avoid in mitochondrial disease. So you would pick drugs that work on different systems, such as carbamazepine in this patient, oxcarbazepine, and you have a wide variety of choices. So one has to be careful in your assessment and management of these children.
Okay. And apart from this one specific category of metabolic disorders, the category of mitochondrial bioenergetic disorders, if one thinks more globally, are there particular clues from either the clinical history or the physical exam or routine laboratory testing that make your antennae go up when you see a person with autism, or that make your antennae go up when you see someone with epilepsy, that say, aha, I need to think about the possibility of an underlying primary metabolic disorder?
Yes, I think there are. I think, particularly in this case, when you have a family history of other children with developmental issues, when you have a mother that has severe migraine, that can point towards mitochondrial disease. But in general, other neurometabolic conditions often present with widespread multi-system dysfunction. Often the children will have failure to thrive. They may have difficulty with fasting. They may have ketonuria in their urine. They may have episodes of nausea and vomiting that can't be explained. And then on laboratory testing, they can have elevated blood ammonias. They can have abnormal organic acids or abnormal amino acids. So I think other clues for specific metabolic disease may include, for example, different odors that the child may emit, that the child just smells different to the family, and that can be a clue to metabolic dysfunction. But I think you have to think beyond the brain when you hear this story, and when you hear this story of regression, you do have to think of neurometabolic disorders, especially if there's been some regression and abnormal findings outside the brain.
Okay, so if I might, for the benefit of the viewers, just try to distill what you just said, some of the clues from a clinical history that might sensitize you as a neurologist to thinking about the possibility of an underlying metabolic disorder would be unexplained multi-system involvement, unexplained developmental regression in one or more areas, things like an inability to tolerate a fast or skipping a meal, unexplained growth retardation, clues from the family history, like other members in the family having the same or similar clinical conditions that are unexplained. And on physical exam, other than growth retardation, what are some other clues?
Yeah, well, this particular child, the exam looked pretty benign, but if you saw organomegaly, for example, that would be a sign that there's metabolic disturbance. Bone growth abnormalities would be a sign of failure to thrive would be signs that indicate that there's a neurometabolic disturbance occurring.
Are there any eye findings or hearing findings that would especially make you concerned about the possibility of an underlying metabolic process?
Sure. The metabolic disease can affect multiple organs, including the auditory pathway, the ocular system, so that ocular changes, hearing loss would be consistent not only with mitochondrial disease, but other disorders as well. That would be in the neurometabolic category.
Okay. And you mentioned from routine labs, things to alert primary care physicians the possibility of an underlying metabolic disturbance would be unexplained abnormalities of electrolytes or acidosis.
Yes, lactate, pyruvate,
blood ammonia.
Elevated blood ammonia, ketonuria. So all these things would be red flags.
This is very helpful. Thank you. The next case I'd like to present to you involves a hypothetical 9-year-old boy who was noted to have language delays in infancy, and they began speech therapy for him at 2 years. At 3 years, he developed partial complex seizures, and then later developed generalized tonic-clonic seizures. Physical exam at around 3 showed multiple Woods lamp positive hypopigmented skin lesions that prompted an MRI that in turn showed tuberous and subependymal nodules. And that in turn prompted some genetic testing that showed a pathogenic DNA sequence variant in the gene called TSC1, confirming a diagnosis of tuberous sclerosis. At 6 years old, the child underwent a neuropsychological assessment that showed him to be nonverbal, but able to effectively communicate using a communication device. And he had low average academic performance, but did have multiple difficulties with respect to social interactions, and had deficits in social emotional reciprocity and nonverbal communication, and in maintaining relationships. This patient also had behavioral rigidities and an insistence on adherence to routines, and he had marked sensitivities to certain sounds. And so overall, the child's clinical history exam fulfilled criteria for autism. So my questions to you are, persons with tuberous sclerosis, this child's specific diagnosis, have a high risk for having seizures. There's a lower but still significantly increased risk in tuberous sclerosis for autism. Is there evidence implicating seizures per se in the development of autism in persons with tuberous sclerosis, or seizures in any other setting implicated in the development of autism?
That's again a very good question and an interesting but tragic case. So, tuberous sclerosis in general has been associated with a much higher rate of autism than in the general population. And here it turns out that the children that are at risk, the greatest risk, are those children that have infantile spasms. And the infantile spasms occur during the first 6 to 7 months of age. And there's no question that those children have a high rate of developing infantile spasms. So this has led to concern. This has led to preemptive treatment. Sometimes tuberous sclerosis can be diagnosed in utero, and often right from the very beginning, before the child has infantile spasms, they have abnormal EEGs. So it usually takes a while for the child to develop the infantile spasms. So the big question there is, can you decrease the risk of autism and cognitive impairment? And they go together in tuberous sclerosis with more selective drugs that may target the mTOR pathway. So just like PTEN, these children are at risk for developing tissue overgrowth, and so they can develop rhabdomyomas of the heart, they can have angiomyolipomas of the kidneys, they can develop subependymal giant cell astrocytomas of the brain due to this overgrowth of tissue. So people have suggested using rapamycin, an mTOR inhibitor, to try to prevent these sequelae from the disorder. Thus far, there's been good evidence that rapamycin can prevent your angiomyolipomas from growing and bleeding. It can stop SEGAs from growing, and it can reduce seizures in patients. What's being studied pretty rigorously now is that whether you can improve cognition with early treatment with rapamycin. And the jury is out on that, mainly because the early studies probably waited too long to treat. So I think if you're going to affect cognition in autism, neurodevelopmental disorder, you have to intervene very early. And there are ongoing studies looking at early treatment before the child even develops infantile spasms with a drug called vigabatrin. So I think there's a lot of hope that we can prevent the autism and the infantile spasms with early intervention with appropriate therapy, so that they go hand in hand together, but that doesn't mean one causes the other. With infantile spasms, it turns out, and this may be different, and again, I think we have to narrow it here. If you look at siblings of children with infantile spasms and tuberous sclerosis, their siblings have a fairly low rate of having autism. So in this particular case, it could be that this early destructive seizure process could lead to autism, but I would really be cautious, and that data has not yet been proven. To really prove that, you'd have to have a trial where you had responders and non-responders to see which children went on to develop autism, which did not. But even then, that would be a hard study to determine, because kids that do not respond to medication may have a different disease burden than someone that does. So getting that answer would be very difficult. I think what we know now, though, is that at the very least, you want to treat these children aggressively and give them the very best chance you can. And the question is, how aggressive? Do you use a tumor-suppressing drug in 6-month-old or not? And I think the jury's still out on that. But I'm optimistic that this is one step in disease-related a personalized therapy. And it won't be the answer for all of autism. It'll be specific to tuberous sclerosis, but I think it's an exciting development that we know the neurobiology and we know the consequences, and now we have a chance to intervene with a very specific drug that targets the molecular pathway. So that's kind of nice to do.
Very interesting. Well, thank you so much. This is going to be of a lot of help to the clinicians who see the children with autism and epilepsy.
Okay, thank you.